Okay, well, welcome everybody to the first webinar for the Australian New Zealand Skull-Based Society. Um, my name is James Bowman. I'm going to be the convener for the webinar, and I'm very excited to be able to present to you today on sinonasal undifferentiated carcinoma. It's a topic that, as skull-based surgeons, and also as medical oncologists and radiation oncologists, that we have to deal with. It's a difficult entity, and it's usually really helpful in this situation to have as much information as you can about managing it. I'm very happy to have three experts come and talk to us today on that. And the first speaker is going to be Bryan Thorp. Bryan is a skull-based surgeon who is based in the University of North Carolina, and he's currently an associate professor there at Chapel Hill. Welcome, Bryan. Thank you very much for coming to speak to us today through the internet at such an early hour for you in the United States. So I might ask you to start with your presentation, and then we'll proceed on to Bryan Chan and Howard Liu, and I'll introduce them shortly once Bryan has finished his talk. So thanks very much, Bryan.
Of course, and thank you all so much for the kind invitation. Um, when I was asked to initially give this talk, I cringed a little bit because the management of sinonasal undifferentiated carcinoma for surgeons can be either really, really fulfilling, or it can be fraught with soul searching. And so I think I'd like to try to discuss a little bit of the decision-making tree with you all, and kind of how I think about the data and integrate that into our multidisciplinary team. I have no disclosures. So I'll start with the punchline, since it is 4 a.m. for me. SNUC is an aggressive pathology, and when appropriate, you need to match the aggressiveness of the pathology. Multimodal treatment is superior to any singular treatment, and there is a trend now at high volume centers to stratify subsequent therapies by response to induction chemotherapy, which Dr. Chan will talk more about. But certainly that gives us a window into the biology of these tumors. I can't emphasize this enough. Negative margins are really critical when you're considering any surgery, whether that be your primary or salvage. And I think you have to be really honest with yourself and the patient. And I think this is kind of where a lot of the decision making comes in place for surgeons. And you absolutely have to be prepared for surprises, whether that be preoperatively with tumor progression in short windows, or microscopic disease that you weren't anticipating in the salvage setting. Additionally, over the last 5+ years, there's been emerging data on variants of SNUC, which are now new pathologies in many cases. And you really have to use that in your metric as you think about which patients are best to attempt primary or more likely salvage surgery in. As we alluded to, sinonasal undifferentiated carcinoma is aggressive pathology. This study from 1973 to 2010, utilizing the SEER database, really emphasized that with a 34.9 and 31.3% overall survival at 5 and 10 years, respectively. This aggressive disease is often advanced initially, which is why we often are talking about multimodality therapy from the get-go. It's very rare that you have a patient with a small lesion that's a SNUC that you're able to resect and feel great about on the front end. And as we all know, these have a large propensity for metastases, which is a huge driver as well in some of the decision tree. This NCDB evaluation I thought was really interesting in that they looked at the overall survival of patients, of all comers, low stage and high stage, and they showed that really there wasn't a big difference. There was a difference in patients that received surgery plus chemoradiotherapy versus patients who received chemoradiotherapy. But when you distilled that a little bit more significantly, and you looked at just late stage disease, you could see that washed out quite a bit. And I think that's where we live as multidisciplinary teams and as surgeons, is really these late stage patients. So when I say late stage, I mean advanced disease. T4A, T4B disease. And then importantly, margin status was a huge predictor of 5-year overall survival in their sub cohort. And so again, I think this is that first inkling into really the importance of patient selection with patients that you know or that you feel strongly that you can get negative margins. Taking away from database studies and looking at kind of singular institutions, the Mayo Clinic presented their data, and it somewhat matched some of the things that we've seen with 5-year overall survival. But importantly, the local control is really, you know, I don't want to say surprisingly, but often is much better than overall survival. And I think that sometimes we make our decisions based on our ability to control things locally. But in SNUC, that's not the pathology that makes a ton of sense into me. And so I think when we present local control, that's great. But really, we have to think about the patient as a whole. And in their group, they really showed that while local control was great with trimodality therapy, despite surgery, of which some of the data was skewed just because of selection bias, the overall survival is still 44%. So I really like to go back to where it started in my mind. So the UVA group was one of the first groups to present on sinonasal undifferentiated carcinoma. And I asked Dr. Levine some years ago why he ultimately decided to do this therapy. And he said that it's a terrible disease and we just had to pick something to start with so we could make some decisions. And I think that really emphasizes what happens at a lot of centers with these challenging pathologies. But what you can see is they looked at 20 patients over a greater than 20-year period, and they essentially planned salvage in these patients. These patients got upfront chemo rads with the plan for salvage surgery. And in their group, those patients that were ultimately able to undergo salvage did better with a 64% overall survival versus a 25% in the non-surgical group, which kind of makes sense because the patients that were never going to be eligible for surgery were advanced anyway. And so again, this skews things a little bit. But I think the really important thing is when you look at the status of the patients, 13 of the 20 are dead of disease. So independent of their initial treatment paradigm, the local control probably outpaced the overall survival. And even more interesting is some of the patients that are alive and with no evidence of disease never underwent surgery. And so again, this kind of shifts into that window of is there a better way to start thinking about how to stratify these patients? And I think that's really where many of the high volume centers are at now. And I won't take anyone's thunder, but suffice to say that across the country and the world, people are using induction chemotherapy to decide who are responders and non-responders. And in the responder group, we know that a chemoradiotherapy upfront approach is often better than a surgical approach. And in the non-responder group, a surgical approach is often better than a chemo radiotherapy approach. Now, again, this is for advanced disease, which is the majority of what we see in sinonasal undifferentiated carcinoma. But again, I think this starts to tease out some of the biology of tumors. So that's what I would say largely agreed upon in many multidisciplinary centers in the States. The area where things start to unravel, so to say, is really when to offer salvage surgery. And we don't have a lot of great data to really guide us because a lot of the data, at least to date, involves all pathologies. And we know that pathology reigns supreme. The difference between esthesioneuroblastoma and a sinonasal undifferentiated carcinoma couldn't be more significant. And so the approach to those patients, in my mind, is massively different. Again, what you can see is in all comers, the initial treatment for patients that were being offered salvage was multiple. Some patients received surgery only. Some patients received surgery and adjuvant. Some patients received neoadjuvant and surgery and then post-op. And so again, I think a lot of it comes down to the multidisciplinary team's gut feeling. But from this paper, what we found, or what was found, is of 47 patients, 35 had progression after planned salvage. That's a huge number. Dural invasion, high-risk pathology, including SNUC, and induction chemotherapy were risks of progression. Now, the induction chemotherapy piece is interesting, and the authors suspect that this could be because these were advanced at presentation, or perhaps there was some tumor heterogeneity, but it was difficult to distinguish that with individual pathologies. But again, this other key factor is that negative margins decrease the risk of progression. they recommended this approach, and I think this is a very reasonable approach when you think about the salvage setting. And again, I think anytime you're considering a salvage setting, honesty has to come in first and foremost with yourself as a surgeon and yourself as the team. Because I think it's very easy to say, oh, I can do that, and say it's just a salvage procedure. But if you're not really affording the patient any benefit, you really, really have to question your desire for surgery versus your desire for cure. Anyway, when a patient comes in and they're seemingly resectable and they have a high-risk pathology, you really need to know what you have in your back pocket, because it's very unlikely that surgery alone in the salvage setting is going to be curative. And we've found that at my institution and at other institutions across the states. And so in general, for me, I follow this to say that I like to reinduce patients that have sinonasal undifferentiated carcinoma that are marginal, like that I don't know that I'm going to be able to get an obvious negative margin. And if they respond well to those, and then they appear to have a local response, and then in those patients, I would consider surgery, again with some caveats. The caveats being that I often start with mapping biopsies, as do other individuals, and really go to the key places first. The orbital apex is where you fail, the infratemporal fossa is where you fail, and the skull base is where you fail. No one fails right in the middle of the field. The nasal cavity and the ethmoid cavity are often places that are very amenable to resection. It's these marginal zones where you have to really, really assess the tissues and be honest with yourself. The Pittsburgh group did a similar study, again, utilizing a database, and they found, again, that the overall survival was significantly worse in high-risk pathology, and they found that anywhere outside of the ethmoid was associated with decreased overall survival. Again, the numbers for these were quite low, and the ethmoid being the highest, so there may be a little bit of bias in the data in that. They presented a similar treatment algorithm and basically noted that with high-risk histology, location is key. And patients that have a favorable location, surgery should be considered, and those that have a unfavorable location, prognosis is poor. Shifting gears a little bit into thinking about some of the subsets within SNUC, SMART-B1 or I1 deficient tumors have emerged as a new pathology and are now listed across the world as I and I1 deficient sinonasal carcinoma as opposed to SNUC. But nonetheless, you can see here a terrible median survival that is greatly impacted by stage. The MD Anderson group looked at 19 patients that were treated at their institution, and this shows comparably terrible overall survival and disease-free survival, as noted. Interestingly, they noted that induction chemotherapy resulted in a 76% less likelihood to die as compared to the non-induction chemotherapy group, which might speak to the biology of this type of disease, and that nasal and maxillary subsites had better survival, again, akin to the ability to surgically resect these areas. They present a modern treatment algorithm, which again includes induction chemotherapy to stratify patients based on response, and the responders, again, chemotherapy, and the non-responders, surgical resection. But I want to draw your attention to kind of the residual disease or recurrent disease area, and that's a site where they offer salvage surgery, again, with the caveats listed before. So I'll quickly present two of my patients just to kind of emphasize some of these principles and some of the things that I did. So this is a patient with who presented with a sinonasal undifferentiated carcinoma, I and I1 deficient, with involvement of the medial orbit and the frontal region. He was treated with 3 cycles of platinum and etoposide with a great response. And did well for about a year. About a year out, he presented to me with recurrence, with frontal extension, extension to the posterior table, extension to the orbit. And we re-induced him, resulting again in a reasonable response, and took him to surgery for an extensive craniofacial resection. When I started endoscopically and cleared all of his critical margins, as I've discussed, and then proceeded with orbital exoneration, frontal craniectomy, free flap reconstruction, subfrontal dural resection, as you can see. And he did well and then we treated him post-operatively with chemo and reirradiation. He did very, very well initially. But unfortunately, on the contralateral side, as you can see here, he developed a right upper eyelid metastases. And then in the cerebellum, you can see a cerebellar metastases about 9 months later. And again, I think this emphasizes some of the points that I just noted, right? Even though all of the things fell into place from a surgical perspective, this was an I1 deficient tumor, and we were swinging for the fences. Now, the patient knew this going into things, but certainly, despite our best efforts to try to mitigate this outcome, this still was driven by his pathology. Switching gears slightly, this is a non-INI1 deficient patient. You can see with extensive disease involving the frontal ethmoid. These are just inspissated secretions in the sphenoid, but nonetheless advanced disease. She underwent a similar induction regimen with a marked response. Was treated with chemoradiotherapy and had no evidence of disease for a year. Approximately a year after completion of the therapy, she had an ethmoid recurrence. She was reinduced, and I took her to the operating room for surgery, at which time I did a planned craniofacial resection, given the fact that I did not need to take her orbit or her skull base. All of those margins were negative, and actually there was no tumor in any of the pathology. And so, again, emphasizing kind of the difference in those types of pathologies. I know I'm running short of time, but I think the key for me, and I think for any multidisciplinary team, is truly that is honesty with the pathology, with the location, and with the addition of other therapies. I think any one oncologist from any discipline thinks that um, uh, their interventions are key, but in this pathology, it's really like a convolution of all of them. No one wins alone in Sinonasal undifferentiated carcinoma, and I certainly think you'll hear that from some of the other experts on the panel.
Yeah, that's fantastic. Thanks so much, Brian. I appreciate that was a lot of information to have to cram in. I've got just a question for you. When you're assessing margins, are you doing intraoperative frozen sections?
I am. And so for the interest of time, in the first patient, I did, all intraoperative frozen margins. And actually, before we took his orbit, we then opened up, we did the frontal craniectomy and opened up the dura. And there was a question of the dural margin. And so I actually waited on permanent on that one because I didn't want to take his eye until I knew that we had cleared the dural margins, because even though there was a small focus of disease on the dura, not the parenchyma, it was still too questionable for me to commit to taking his eye at that time. And so I planned a staged operation in that regard, and actually brought him back the next week and did the exoneration once we knew that was negative. But I generally trust the frozen margins. But if they're equivocal, I am actually a little bit more cautious and will plan a staged procedure, because I can't think of anything worse than taking an eye in someone and then leaving positive margins elsewhere. That to me is unacceptable.
Mm. And then do you think there's a role for upfront surgery before chemo rads in any of these patients?
Yeah, I love this question. Because it's like when surgeons ask to surgeons, it's like we're trying to um, so in advanced SNUC, I am finding less and less of a role for upfront surgery. And I think the reason is not my ability to control things locally. It's really distant disease. Because I think you can do a wonderful surgery in someone, you get 3 month scans and the local site looks great, and then they've got pulmonary metastases. And really, so I think there is something to, priming these advanced tumors with chemotherapy. I've had a handful, and I mean a handful, I can count them on one hand, of patients I presented with very, very early disease. They're usually on blood thinners and they're bleeding, and you get lucky. In those patients, I think if there's absolutely no morbidity associated with a surgery, I don't need to take the eye, I don't need to do a big subfrontal dropout. I think that those are very reasonable patients to have that discussion with, because it's almost no harm, no foul. And I don't mean that in a kind of a an arrogant way, but you're able to balance kind of the quality of life and things with those. But those are few and far between.
Okay. That's excellent. Okay, we might move on. Thanks so much, Brian. We've got Brian Chan now to talk to you now that we're leading into management with chemotherapy, whether it be induction or as part of a regime. But Brian did his fellowship at the University of Toronto at Princess Margaret Centre in Canada. He works on the Sunshine Coast here in Queensland, and he does have a special interest in SNUC. So I thought he'd be a good person to talk to us about his role and medical oncology role in SNUC. So I'll hand over to you now, Brian. Thank you very much. Just unmute yourself, Brian. Brian, just take
Can you hear me now?
Yeah, all good now.
Okay, sure. Sorry. Thank you for the introduction, James. Actually, I thought you'd asked me to speak about this, so this is actually what I'm going to be talking about rather than systemic therapy specifically.
That's fine.
This is our statewide review that we've done on SNUC over the last 40 years. And we presented this also at the Clinical Oncology Society meeting in November last year. So this is more of an epidemiological talk, but I'll go through it now with you. So, sorry, just need to move through. So my disclosures, I'm not a surgeon, and I'm sorry, but I'm not a skull-based expert as well. I'm a medical oncologist with mainly thoracic and head and neck clinical expertise, but my research interests are in quality improvement and health service research, which is why I'm here today. So first and foremost, I really have to acknowledge that this project that we did was really a patient or consumer-driven and funded project. So I had two patients in the recent times with SNUC who were really quite frustrated at the lack of active research in their cancer locally. And so we raised money, we established the Rare Cancer Care and Research Fund here on the Sunshine Coast, and then we used that money to partner with Cancer Alliance Queensland, which are the people in the photograph, to bring you the data that we show you today. And this work is also in memory and in honor of Neil and Mel, who unfortunately passed away late last year. So as you all know, head and neck cancers are rare, making up only 3% of all cancers in Australia. And nasal cavity and paranasal sinuses are even rarer, making only 4% of that, with most being pharynx or oral cavity. Now, with regards to sinonasal undifferentiated carcinoma, obviously you're all better experts at this than I am, but the WHO describes this as tumors without any identifiable lines of differentiation, affecting the nasal cavity, paranasal sinuses, and as our previous speaker mentioned, they're highly aggressive tumors. They have a proclivity for metastasis, and combined with late diagnosis, they obtain a poor prognosis. We know that the current paradigms for treatment are multimodality, with surgery being the cornerstone, supported by radiation and chemotherapy as well. But what's unknown still is the optimal sequencing of therapy, and I still think even with all the data sets that Bryan just showed us, these are often single sites limited by numbers as well. So our aim was to try and establish a Queensland first research ready data set that will allow us to look at the epidemiology of SNUC in Queensland, examine the patterns of care, and ultimately the survival as well. So before I go into the methodology on, I just wanted to describe basically how we get our information and big data in Queensland. So Cancer Alliance Queensland is a group based in the PA hospital, and really their goal is to support clinician-led quality improvement. They also manage the Queensland Cancer Register under the Public Health Act, and also the Queensland Oncology Repository and the Quality Assurance Committees under the Hospital and Health Boards Act. Really, the workhorse is the Queensland Oncology Repository, and our unique legislation here allows us to link and match patients across both private and public sectors, and using things like cancer treatment, radiology and mortality and everything. And then these allow the gazetted quality assurance committees to review patient care and perform related research as well. Diagrammatically, the Oncology Repository looks like this, with multiple sources below. So it drags in information on systemic therapy, radiation, surgery, everything radiology, multidisciplinary team discussions, and including death data. So over 3.25 billion pieces of information are brought together and processed duplicates are removed, and they're matched such that you get 900,000 matched patients over the last 15 years that this has been running. For each individual patient with cancer in the state, you can then have a complete lifelong record that works in real time. And most of you would have interacted with this at your MDTs via the Queensland Oncology online platform, or COOL. So our methodology is that we identified the cases of SNUC from the oncology repository from 1982 to 2022. And we had 2 dedicated data analysts that were extracting extra information like the demographics, tumor characteristics, and we also had an experienced surgeon look at stage and ensure that wherever things were not in the 8th edition, they were updated to that. Investigations were brought across, and again with pathology, we had an anatomical pathologist, an experienced one from the PA hospital, look at all equivocal cases to ensure that we're dealing with the correct pathology. Lastly, treatment, recurrence, and death data were drawn across. So in total, 158 data fields were recorded in the Queensland Oncology online repository, thus creating the SNUC Clinical Quality Registry, from which all this information is coming today. So these were our results. So a total of 58 cases of SNUC were identified in the 40-year period, thus giving us an incidence of 0.01 per 100,000. To put this into context, I also look after NETs and other rare cancers, which a rare cancer is defined as less than 5. So this is indeed a very rare cancer. The incidence in our state has increased over the decades, as you can see in the graph below. And this is thought to be due to aging population, increased awareness, and improved diagnostics. These are the baseline demographics of the patients included. Of the 58 patients there, you'll see there's a slight male predominance, which is in keeping with historical reports, with a median age of 55. Whilst majority of patients came from a major city, there was still a significant proportion of patients who came from regional and remote areas. And obviously that's very important when we're talking about a rare population that requires such significant expertise from high volume centers. In addition, 2/3 of patients had one or more comorbidity, which could really limit the impact of treatment choices as well. In terms of primary site, again, in keeping with historical records, nasal cavity followed by maxillary and ethmoidal sinus were the most common primary sites in Queensland. And the 8th edition staging at baseline showed that 50% had stage 4 disease, with 17% having stage 3 disease, accepting that stage 4 includes any of the T4s involving adjacent structures. There were 22% of patients who we were unable to stage, but bear in mind that these are records going back to the 80s, and some of them were paper and had been destroyed. When we look at treatments at baseline, this is how patients were treated across the state. Interestingly, 14% of patients chose not to have any treatment at all. Whether or not that's patient preference or performance status is unclear. Of the 50 that did go through active treatment, 10 went through the most aggressive trimodality, being in the form of surgery plus concurrent chemoradiation. The vast majority of patients, though, got dual modality therapy, with concurrent chemoradiation being the most common, followed by surgery and radiotherapy. About 26% of patients received single modality therapy only. Now, I'm not a surgeon, but these are the surgical procedures performed in the table there. So there are 29 in total, representing 44% of patients having surgery at some point during their treatment journey. This graph here shows you where the patients had their surgery, and on the left shows that 27% were able to have it in their local hospital and health service, whereas the vast majority had to travel to a different center. The different colors here demonstrate blue being public tertiary facilities and orange being private facility, and then there was one patient treated in a non-tertiary public facility. Of the 17 patients received surgery at baseline, and the median time from diagnosis to surgery was 25 days. Of those 17, 16 had subsequent treatment with either radiation or chemotherapy, or both combined. And the median time between surgery and the next treatment was about 47 days. Neck dissection was performed for 7 of those 7 patients, 1 at baseline and 6 at the time of recurrence or progression, all found positive nodes. And I guess for me, it also showed extranodal spread, which was interesting as well. Radiation therapy was received by nearly 90% of patients, underlying the importance of this treatment modality for patients as well, particularly as we heard how surgery can be quite disfiguring and morbid. For those who had curative intent radiation, the median doses were 60 gray in 30 fractions, but for those who had palliative intent radiation, there was a range of 20 to 40 gray and up to 25 fractions. Again, this graph here shows you that the reasonable proportion of patients still had to travel outside their health service to receive treatment, and that in blue shows you that nearly all radiation was given in the public sector. What about chemotherapy? As a medical oncologist, this is something that interests me, of course, and at baseline, a third of patients received chemotherapy, and most of them were with curative intent. Again, the regimens used were all platinum-based with all the different types listed above. And below here, you can see that thankfully this time, a few more people were able to access treatment closer to home. Unfortunately, a third of patients experienced recurrence as of the time of data cutoff in October last year, and the median time to recurrence was approximately a year. We can see here that there is an earlier peak of recurrence in under a year for those treated with single modality in the blue bar, and also for trimodality, which is in the gray bar. And interestingly, we hypothesize that these are probably the very aggressive and poor prognostic group who were offered all treatment options at the get-go. There's a second peak of recurrence at the 2-year and over 2-year mark for those receiving dual therapy in orange or trimodality therapy in gray if you make it that far. What are the treatments that people received at recurrence? Well, we heard earlier about salvage surgery. And again, for the majority of patients, the single modality was used, and that was surgery followed by radiation. Interestingly, again, about 30% of people chose or were not suitable for any further treatment at the time of recurrence. Unfortunately, as a medical oncologist, again, and my other interest is in palliative chemotherapy for those with metastatic disease. And again, these were limited by very small numbers, and NP meaning non-platinum and P meaning platinum. And again, with such small numbers, it's very difficult to make any inferences from efficacy of individual treatments. This is the overall survival for our Queensland cohort by modality at diagnosis. So those who received trimodality therapy have the best overall survival, with the median not being reached, versus those who had dual therapy or single modality therapy, with median overall survivals of 2.5 and approximately 2 years respectively. If we drill down now further into dual modality and we say, okay, well, what seems to do better? Whilst chemoradiotherapy concurrently appears to have a better survival in this subgroup, really, I must caution you that the numbers are really small, and therefore meaningful comparisons can't be made. And these really should only be hypothesis generating. What were the survival outcomes? Well, the 5-year survival outcome was 34% for the entire period of 40 years. But the good news is that this has improved from the 80s, where it was 20%, to now 30% in the current decade. So in summary, SNUC is an extremely rare cancer, and that multimodality therapy is associated with better survival, but unfortunately, a lot of patients are still required to travel. Unfortunately, with insufficient numbers, we were unable to formally compare the relative benefits of each of the different modalities. And although survival is poor, the hope is that this is improving over time. We do now have a Queensland SNUC quality registry that's been established, and hopefully this will allow us to drive research forward in the future. Speaking of the future, we're now also collaborating with the Australian Rare Cancer Portal, which is our national portal for those with rare cancers, and also with the Stafford Fox Rare Cancer Program associated in Victoria. I suppose it would require national effort to create a national SNUC registry, but this would then allow us to answer some of the questions with more power about the optimal sequencing of therapy, such as neoadjuvant or induction therapy, and what about the role of immunotherapy? You might have noticed there was one patient who received immunotherapy, but again, we can't make any real inferences from that. I guess the wish from the two patients that funded this project was that they really wanted to have a better understanding of etiological factors. And I guess as medical oncologists, we better understand the molecular and the genomic information about these cancers, then we potentially can find newer targets and biomarkers for both treatment response and also for prognosis. Thank you very much for listening, and happy to take any questions if you have any.
Thanks very much, Bryan. I think, your point about collaboration to get more information with respect to management of these lesions is really important. And if anything, it should be an international one because it's such a rare cancer, but it's something that really does, I think, make our decision making more difficult because we have such little information, I guess, to assist us. I think just in the interest of time, Bryan, we might move on to Howard because we have talked about radiation, but not through him, so to speak. Howard Liu is a radiation oncologist who practices at Icon Cancer Care and also the PA Hospital where we work. He did his specialist training through a variety of hospitals in Queensland and did a clinical research fellowship as well. Howard works with us regularly, and appreciate, Howard, you coming to spend some time with us tonight talking about radiotherapy planning for SNUCs. Thank you very much.
Thanks, James. I hope you can see the slides.
Yep.
Great. So I'm just going to take a different approach rather than the data. I'm going to go through how I approach a patient with SNUC and how I would consider planning them with radiotherapy. So radiotherapy planning for sinonasal malignancies are in general very technically challenging. Patients with SNUC especially present with advanced disease, so often have to deal with, for sinonasal malignancies, how can I improve radiotherapy dosage to the tumor but protect the adjacent critical organs like the eyes, visual tract, temporal lobes. So there is often a need to compromise tumor coverage against acceptable risk of normal tissue damage in consultation with the patient. So radiotherapy planning is now purely volume-based on CT imaging. What that means is I need to delineate target volumes covering the tumor, covering the microscopic disease, any elective areas, and then delineate the organs at risk to set parameters where I can fulfill the maximal tumor control probability against minimizing normal tissue damage. And the way to deliver radiotherapy these days is through a modulated technique. The standard now is volumetric modulated arc therapy. This is a way of delivering beamlets of radiotherapy that shape around the target volume and minimize the dose to normal tissue so that we can maximize the therapeutic ratio. For me to reduce my margins, patients will need to be immobilized through a thermoplastic shell. Treatment is delivered through image guidance so that we can minimize day-to-day setup variations. So this is volumetric modulated arc therapy, or VMAT. This is a technique that is where the machine head moves around the patient, delivering beamlets of radiotherapy. The treatment is typically completed in 5 minutes or less, and really shapes the radiation dose around the target volumes, giving us a chance to preserve the function of normal tissue. So this is the beam's eye view looking through the treatment head. This is a patient with a SNUC where we're treating the primary and neck. The beamlets of radiotherapy is shaped around the target volume. There's collimation of the radiation to avoid damage to the normal tissue. and the machine head is delivering radiotherapy continuously around the patient, keeping the treatment to a short time. Now, patients will all need to be immobilized with a thermoplastic shell. This is customized to the patient. It covers the head and neck region to keep them still. And this allows me to reduce my setup margins to 2 to 3 millimeters. This is an example of a modern linear accelerator, which is the workhorse of radiotherapy delivery. On the left there, that's the treatment head, which can move around the patient, delivering the radiotherapy. There's onboard imaging capabilities, which can capture daily cone beam scans, cone beam CTs. And there's the treatment couch, which can shift the patient into the correct position to ensure accuracy of radiotherapy delivery. Now, by using image guidance, we can ensure that the radiotherapy is delivered accurately. So the scan on the left is a planning scan. The scan in the middle is the daily cone beam CT that is acquired. And this is fused onto the planning scan, and the patient is shifted to the correct position to ensure that the radiotherapy is delivered accurately. Now, in terms of volume-based planning, for definitive cases, my clinical target volume, which is what I need to encompass to cover gross disease and microscopic disease, will be delineated based on CT, MRI, and PET. The gross disease of the primary site and nodal site, I typically give a 5 millimeter margin, more if there's any uncertainties about the imaging modality. This will get the highest dose in terms of my prescription. Electively, I would treat the retropharyngeal nodal basin, level 2 to 4 in the neck, and cover the involved sinus. We'll then need another 3 millimeter margin to account for any day-to-day setup variation. This is in the setting of image guidance and using immobilization techniques. So this is an example.
Howard, sorry, I was just going to interrupt you. When they talk about rear radiation or the option of rear radiation after a patient's had salvage surgery, do you think there's a role for that in SNUC, or have you had experience with that?
Not in SNUC, in sinonasal SCCs, yes. And it really depends on what the volumes are previously in the era of modulated radiotherapy. So if we can precisely target the area of concern, and there is the ability to deliver more radiotherapy without overdosing adjacent structures, then that's a possibility.
And what's your standard dosing for a SNUC? Is that a 66 gray type dosing, or do you vary it a little bit?
Yeah, so I'll go through that, but 66 gray is what I aim for in a definitive setting.
Okay.
So this is an example of definitive radiotherapy volumes. You've got the gross disease in the primary on the left side, a 5 millimeter margin to account for microscopic disease. And this is a patient that had disease going into the left orbit. So you can see that the clinical target volume goes into the orbit adjacent to the extraocular muscles. This patient also had retropharyngeal nodes and neck nodes. So the gross nodal disease is given a 5 millimeter margin to account for microscopic disease. And then electively, the volume in orange covers the retropharyngeal nodal basin, level 2 to 4 of the neck. So as James alluded to, in terms of definitive dosing, I would typically try to dose escalate to 66 gray and 33 fractions. But for the elective volume, I will simultaneously deliver a lower dose of 56 gray, given the lower risk of disease. This will be given 5 fractions a week to a treatment period of 6.5 weeks. The problem here is there's a lot of adjacent critical organs. When I'm dose escalating to 66 gray, puts these adjacent organs at risk of significant toxicity. So there is a need to optimize target volume coverage but also respecting dose constraints of normal tissue. The degree of compromise is purely based on discussion with patients and what potential salvage options there are. So in this case, this patient had disease going towards the orbit. The decision was to increase coverage of the tumor against the left globe. The area marked in green is putting the globe at risk of about 5% retinopathy. The patient was willing to accept that, so we proceeded with covering the tumor against the left globe. But I think the treatment paradigm is moving. We're looking globally. I think the radiation oncology community is supporting the role of induction chemo. So in terms of post-induction, my target volumes would typically cover the gross disease of the post-chemo. So if there's any cytoreduction with a 5mm margin, I will still cover the gross disease of the pre-chemo volume with a 5mm margin, just to a lower dose. And electively, I would cover the retropharynx level 2 to 4 and the sinus involved. In the post-induction setting, if there was good cytoreduction, I would reduce the dose to the pre-chemo disease. Any post-chemo disease, I still treat up to 66 gray and electively to 56 gray. This will be delivered simultaneously, 5 fractions a week over a 6.5-week period. Now, in the adjuvant setting, I would be using the same principle that I would do for a sinonasal SCC, but traditionally at our institution, we've typically given chemoradiotherapy for advanced SNUCs. But in the adjuvant setting, I would be covering the tumor bed and any high-risk areas with a 5 to 10mm margin, using preoperative imaging and in consultation with a skull-based surgeon. I'll still cover the surgical bed and electively treat the retropharynx level 2 to 4 if it hasn't been dissected. So this is not a SNUC, this is a sinonasal SCC, post-orbital exenteration. The high-risk clinical target volume is a margin around the tumor bed based on discussions with the skull-based surgeon and preoperative imaging. I'll use a lower dose to cover the surgical bed. In the adjuvant setting, if an R0 resection can be achieved, then I'd be looking at dose reducing to 60 gray, a lower dose of 56 gray to the surgical bed, and 54 gray to the elective volumes. Now, the acute toxicities or toxicities during radiotherapy that I typically counsel patients about include fatigue, headaches, nausea, vomiting, mucositis of the nasal cavity and pharynx, dry mouth, loss of taste, dysphagia, dermatitis, and hair loss. In the late setting, so this is 3 months post-radiotherapy, the fatigue and dry mouth can persist, as well as the dysphagia and lymphedema of the neck. But in terms of more critical late effects, brain radionecrosis, typically quote a 3% risk, but this will depend on the extent of disease and how much I would cover in terms of going into the brain. Myelopathy risk, less than 1%. In terms of vision loss, again, I typically aim to keep this risk at 3% or less. In terms of bone, skull-based radionecrosis is very rare at the dose of 66 gray, so less than 1% is what I quote. In terms of the endocrine system, once we get above 50 gray, there is a significant risk of panhypopituitarism. So often if the sphenosinuses is involved, I would get the endocrinologist involved. The neck is treated, the risk of brachial plexopathy is less than 3%. Now, in terms of outcomes, the data is limited. When I speak to patients about chemoradiotherapy, I'll be talking about a 5-year overall survival of about 40%. And this is for advanced disease. This is data from an individual patient data meta-analysis looking at different modalities. So Moran looked at surgery plus radiotherapy and chemoradiotherapy in trimodalities, chemoradiotherapy 5 years, 40%, which is consistent with Bryan's data. Surgery plus radiotherapy, the paper estimated the 5-year overall survival of 60%, trimodality 50%, but once you adjust for disease stage, there's no significant difference in overall survival. So where to from here? I do think that the paradigm in managing SNUCs is shifting towards induction chemotherapy. The MD Anderson experience looked at induction chemo and found the responders followed by chemoradiotherapy an excellent overall survival at 81%, compared to non-responders at 0%. So no one survived till 5 years if they were non-responders. And the responders to induction chemo with chemoradiotherapy, their 5-year local regional failure-free survival was above 70%, distant metastatic failure-free survival of 83%. All right, so I'll stop there. I'm happy to take any questions.
That was great, Howard. I'm interested with your patients that become pan-hypopit. What's the sort of incidence of that? I guess we're not talking so much about SNUC, but that area of the skull base that can get irradiated, particularly for, I guess, for women who want to have children and things. So what do you quote for them?
So if I estimate the pituitary gland dose to be above 50 gray, the rate goes up very quickly. So over 5%. If it's kept under 50 gray, anything more, it goes significantly higher.
Mm-hmm. Yeah. And I guess the rate of complication, if you were to re-irradiate in these patients, obviously would be a different risk, wouldn't it?
Yes. So it's really depend on what volumes have been treated previously, what the organs at risk have received, and ideally in a re-irradiation setting, really if we can define the highest risk area, we should be able to improve that therapeutic ratio of maximizing tumor control and limiting damage to normal tissue.
And Bryan, do you collaborate with the rad-oncs once you've done in this situation? If you have to do re-irradiation, because obviously usually they're getting upfront or potentially induction chemo. What do you do at Chapel Hill?
Yeah, it's a great question. So certainly echo some of the things that Howard said. I think one key point in re-irradiation is, are you bringing in fresh tissue or not? And so often, in salvage settings, we are talking about free tissue transfer. And I think that does change the paradigm a little bit. But we actually, what I do is we meet and we actually target those high-risk locations. So in the patient I presented that we did re-irradiate, we didn't re-irradiate the entire initial field. It was largely isolated to the orbital apex and the inferior medial orbit, where the prior dose was less than the original main treatment volume dose. And so a lot of that is comparing the initial treatment fields, whether or not we have fresh tissue, and then what the pathology showed.
So in reality, do you think that these patients are, I mean, the fact you're rearranging those areas, do you think it's that they're failing locally then rather than distantly? And that's the reason for the treatment, because we're not really usually giving them more chemotherapy with that reirradiation, are we?
Yeah, it's a great question, and we lack the data to help us make that decision, right? I think we feel pretty bad about an acute local failure, right? I mean, I think that's something that any treatment team, surgeon, non-surgeon, really struggles with, is an acute local failure, because then you really have to question, was any of this worth it, right? And so I think you're kind of padding the books a little bit for local control with that. And you're right, because you lack some of the other systemic options, you're kind of left out to dry.
Yeah. Look, I think that was a really great discussion on SNUC. Sorry, Ben, you wanted to say something?
Yeah, look, I'd just like to correct Howard on something. Howard, you said if you failed induction chemotherapy, then your survival was 0. But in EHAB's series of 95 patients, which were published in JCO, if you fail your chemotherapy, your induction chemo, and then you proceed on to surgery plus or minus radiation or chemorads afterwards, your overall survival at 5 years is about 45%. So I agree with you that the game has moved completely, and that induction chemotherapy is the treatment of choice. I think that's been established for a 5-year period now. And that just determines responders and non-responders. And if it means you've got to be a responder, you do fantastic if you get chemoradiotherapy. But if you don't respond, that means you do try and do surgery, and that surgery can be morbid, because we know if you've gone to induction chemotherapy and you haven't responded and you then continue with chemorads, your survival is 0. So you have to then have that morbid surgery if the patient wishes to survive. But otherwise, I agree entirely with you, Howard, as you know.
Great.
Yeah, I agree with that. I certainly feel that the data is really supporting induction chemo in selecting patients for chemoradiotherapy or surgery. And that paper suggests that none of the chemoradiotherapy patients who didn't respond to induction survived.
Yeah, I mean, I think we still need to learn more about this entity, and I mean, I guess that's what we're trying to do by having these discussions. So I just want to thank everybody, thank the panelists for participating tonight. It's been very interesting, and I just want to just let you know about the next topic, which will be on in 2 months' time. It's going to be on cavernous sinus pathology, and particularly on the classification system that gets used. Richard is going to talk at that particular discussion meeting, but we're also going to have Juan Collis, Ferranda Miranda speaking to us, as well as Ben Jonker. And we're also going to have our annual meeting afterwards at the end of that discussion. So I look forward to catching up with you all then to further our discussions on the webinar.
Thanks, James, very much. And just a reminder, once again, James highlighted the AGM is after the next meeting. So please join us. And James is keen for some feedback from the membership to understand what topics we should cover in 2024 and 2025. So if not for General Society business, even for our webinar, we'd really appreciate the feedback. And thank you very much. Thanks, James. Thanks all our speakers.
Thanks, everybody.
Yeah, thanks, James. Thanks, speakers.